Welcome, everyone. This is Malia Valentine from the Integrated Care Resource Center, or ICRC. Thank you for joining us today for this introductory webinar titled Working with Medicare, Medicare 101. Slide 2, please. Before we get started, I'd like to quickly go over a few logistics. For those of you joining by phone, you can view the slides by logging into Zoom. You can find the directions for doing that in the calendar appointment for today's webinar, which you should have received via email after registering. We will be recording this call so you can revisit today's presentation or share the recording with colleagues who are unable to join. We will send you a link to that recording and the slide deck soon. We also emailed the slides to all registrants on April 16th. To eliminate background noise, all attendees' phone lines will be muted during today's presentation. We will have a Q&A segment at the end of today's webinar, but we will keep the phone lines muted, so we ask you to submit questions via Zoom using the Q&A icon at the bottom of your screen. You can submit your questions at any point during the webinar. If you'd like to use the closed captioning feature, click on the More option in the Zoom toolbar at the bottom of the screen and select the Captions option. You are also able to edit the caption settings to adjust the text size by going to the Subtitles Settings option. As you leave the webinar, a short evaluation will pop up on your screen. We'd really appreciate if you would just take a minute to share your feedback. Slide 3, please. This webinar is part of a series of ICRC resources for states on Medicare and dually eligible individuals. The Working with Medicare webinar series is designed for all states interested in improving Medicare and Medicaid coordination for dually eligible individuals. The ICRC website includes recordings and slides from past Working with Medicare webinars, as well as written tools and e-alerts on Medicare-related issues that are important to states. You can find these resources on the ICRC website at integratedcareresourcecenter.com. Slide 4, please. Here's the agenda for today's webinar. First, I will introduce our presenters. Next, we will provide an overview of the Medicare program. Then we will share a brief refresher on who dually eligible individuals are and how they become eligible for and enroll in Medicare. Following that, we will discuss the roles of Medicare and Medicaid in serving dually eligible individuals and some potential overlaps in Medicare and Medicaid coverage that can make it challenging to coordinate care for this population. And finally, we will wrap up with questions and answers. Slide 5, please. During today's webinar, we will hear presentations from 3 of ICRC staff members, myself, Malia Valentine, and Kenneth Lim from Mathematica, and Nita Joseph from the Center for Healthcare Strategies, or CHCS. Slide 6, please. We would also like to thank 2 ICRC subject matter experts, Haley Gallo-Sutherland from Mathematica and Nancy Archibald from CHCS, for their support in the development of this webinar. With those brief introductions taken care of, I will now hand it off to Ken. Slide 7, please.
Thanks, Malia. In this section, I'll provide a high-level introduction to the Medicare program. Slide 8, please. Medicare is a federal program that provides health insurance coverage to 65 million people. It was created as part of the Social Security Act of 1965 and is financed through a combination of payroll taxes, enrollee premiums, general federal revenue, and other sources. Slide 9, please. Individuals may qualify for Medicare through 2 primary pathways. The first is age. Most people who are age 65 or older qualify for Medicare regardless of their income or health status. The majority of these individuals qualify for Medicare because they or a spouse earned 40 or more work credits with Social Security or railroad retirement. Older adults without these work credits may also be eligible to purchase Medicare coverage if they meet specific citizenship or residency requirements. The second primary pathway is disability. People who are under 65 can qualify for Medicare if they have received Social Security disability insurance payments for at least 2 years, or if they are diagnosed with amyotrophic lateral sclerosis or ALS. People with ALS have no waiting periods before their Medicare coverage begins. In addition to age and disability, individuals may qualify for Medicare if they are diagnosed with end-stage renal disease or ESRD. People with ESRD have shorter waiting periods before their Medicare coverage begins. Slide 10, please. Medicare is comprised of different parts that provide coverage for different types of care and services. Part A covers inpatient care, which includes hospital and skilled nursing facility stays. It also includes hospice care and home health care after a hospitalization or skilled nursing facility stay. Part B covers outpatient care, such as doctor's visits, preventive care services, skilled home health care for people who are homebound, and durable medical equipment. Part D is prescription drug coverage that is offered through private plans. Part C, which we'll talk about in detail in a moment, is an option through which Medicare beneficiaries can receive their benefits through a private managed care plan. Part C is also known as Medicare Advantage. Now we'll talk more about the differences between traditional Medicare and Medicare Advantage. Slide 11, please. Traditional or original Medicare pays healthcare providers for each service they provide through a system known as fee-for-service. Beneficiaries who receive their coverage through traditional Medicare have access to a wide network of providers. They can essentially go to any doctor or hospital that accepts Medicare anywhere in the United States. Traditional Medicare covers most medically necessary services and supplies in hospitals, doctor's offices, and other healthcare facilities. Traditional Medicare does not cover certain services such as long-term care, most dental and vision care, hearing aids, and other specific services. We'll talk about beneficiary costs for Medicare coverage in a few slides, but I wanted to note here that Medicare coverage requires individuals to pay for premiums, deductibles, and copayments. In traditional Medicare, there's no maximum limit on these out-of-pocket costs. However, Medicare beneficiaries who use traditional Medicare may choose to purchase Medigap plans, which are supplementary private health plans to help pay for out-of-pocket costs that Medicare does not cover. It is worth noting, though, that these plans are not typically affordable for people who have incomes low enough to qualify as dually eligible, but most dually eligible individuals will have their Medicare cost-sharing amounts covered by Medicaid. Slide 12, please. In contrast to traditional Medicare, Medicare Advantage, or Medicare Part C, provides Part A and B services and often Part D prescription drug benefits through private managed care plans. These plans are paid a capitated per member per month rate to provide this coverage, which differs from the fee-for-service structure of traditional Medicare. Unlike traditional Medicare, Medicare Advantage enrollees are typically restricted to a network of providers that contract specifically with the Medicare Advantage plan. Medicare Advantage plans vary in terms of their characteristics and plan offerings. For example, different plans may have different premiums, cost-sharing requirements, or prescription drug coverage. Additionally, Medicare Advantage plans must set a maximum limit on out-of-pocket costs and individuals who enroll in these plans are not allowed to purchase Medigap policies. I'll also note that when someone becomes eligible for Medicare, they'll receive their benefits through traditional Medicare unless they choose to enroll in a Medicare Advantage plan. Slide 13, please. One key feature of Medicare Advantage is that plans may offer supplemental benefits that are not available to people who receive coverage through traditional Medicare. So in addition to covering the required Medicare Part A and B benefits, Medicare Advantage plans can offer things like vision, dental, and hearing benefits, over-the-counter allowances, or gym memberships. In addition, in recent years, Medicare Advantage plans have received more flexibility to offer additional benefits. For example, while most supplemental benefits need to be health-related, meaning they have a direct impact on the individual's health, the definition of health-related has been expanded, so now plans can offer supplemental benefits like caregiver support, in-home support services, adult day services, and non-emergency medical transportation. Plans can also design benefits to meet the specific needs of people with particular conditions or diseases. In addition to offering health-related benefits to people with particular conditions, Medicare Advantage plans also now have flexibility to address the social needs of enrollees with certain chronic conditions through what are known as Special Supplemental Benefits for the Chronically Ill, or SSBCI. These benefits include coverage for things like non-medical transportation services, food and produce, and structural home modifications. Slide 14, please. This slide describes Medicare costs to beneficiaries for 2025. First, for Part A, there's no monthly premium for people who have at least 40 work credits. However, there is a $1,676 deductible for each inpatient benefit period, and there are different levels of coinsurance for inpatient care based on the number of days a person is hospitalized or stays in a skilled nursing facility. These amounts are typically covered by Medicaid for people who are dually eligible. People who do not qualify for premium-free Part A can purchase it by paying a monthly premium if they meet certain citizenship and residency requirements, as I mentioned earlier. For Part B, the standard monthly premium in 2025 is $185. Medicare beneficiaries with high incomes may pay more than that, but dually eligible individuals will typically owe the standard premium amount, and many of these individuals will have that premium covered by the state through Medicare Savings Program benefits. The Part B deductible is $257, and coinsurance for services covered by Part B is 20% of the Medicare-approved cost for most services. These costs will also generally be covered by state Medicaid programs for people who are dually eligible. When a Medicare beneficiary uses Part C, they may have premiums, deductibles, and other cost sharing for that plan, which varies by plan. It's important to note that Medicare Advantage enrollees must continue to pay the $185 monthly Part B premium as well. Finally, for Part D, premiums and cost sharing also vary based on the prescription drug plan. For dually eligible individuals, the Low Income Subsidy Program covers premiums and most cost sharing for these plans. Slide 15, please. Now I'll briefly summarize key takeaway points from what we've gone over in this section before moving into the next section of our presentation. First, Medicare is a federal health insurance program comprised of different parts, and each part covers different benefits. Medicare beneficiaries have the option to receive benefits through traditional Medicare or through managed care plans known as Medicare Advantage or Part C plans. Unlike traditional Medicare, Medicare Advantage plans can provide a variety of supplemental benefits in addition to Part A, B, and D benefits. Slide 16, please. In this section, I'll talk about how people become duly eligible for Medicare and Medicaid, the different types of dual eligibility, and how duly eligible individuals choose to receive their Medicare coverage. Slide 17, please. We're going to start by going over some basics of what it means to be duly eligible. To become duly eligible, an individual must qualify for both Medicare and Medicaid. We've already described the ways one can become eligible for Medicare through age or disability, so we'll spend this time specifically on Medicaid eligibility. To be eligible for Medicaid, an individual must meet income and asset criteria, which varies by state. In addition, the person must be a member of a Medicaid eligible group, such as adults with disabilities or older adults. So to become duly eligible, an individual needs to qualify for both Medicare and Medicaid. This means the person must meet the federal eligibility requirements for Medicare and the state's eligibility requirements for Medicaid. Slide 18, please. There are two types of duly eligible individuals, full benefit and partial benefit. A full benefit duly eligible individual is a Medicare beneficiary who also meets all of the criteria to qualify for full state Medicaid benefits. They get comprehensive Medicaid coverage in addition to having Medicare coverage. A partial benefit duly eligible individual is a Medicare beneficiary who does not meet all of the categorical and income and asset limits for full Medicaid benefits in their state, but they still have low enough income and assets to qualify for Medicare Savings Program benefits. Depending on the Medicare Savings Program for which they qualify, Medicaid will pay for some or all of their Medicare Part A and B premiums and cost sharing. Partial benefit duly eligible individuals do not qualify for any other Medicaid covered benefits, such as long-term services and supports. For more information on the different Medicare savings programs and categories of dual eligibility, please see the CMS resource linked to at the bottom of this slide. Slide 19, please. Duly eligible individuals, like all Medicare beneficiaries, can choose how they will receive their Medicare coverage, and they have many different coverage options. They can receive their coverage through traditional Medicare, or they can enroll in a Medicare Advantage plan. In some states, duly eligible individuals can also enroll in programs that offer integrated Medicare and Medicaid benefits, such as Medicare Medicaid plans, which operate under demonstrations in the Financial Alignment Initiative, or programs of all-inclusive care for the elderly, or PACE, which provide comprehensive benefits to people who need a nursing facility level of care but live in the community. Within Medicare Advantage, many duly eligible individuals can decide between a special needs plan or SNP, such as a dual eligible SNP, institutional SNP, or chronic condition SNP, and a non-SNP Medicare Advantage plan. Dual eligible SNPs or D-SNPs are Medicare Advantage plans that are designed specifically for people who are duly eligible for Medicare and Medicaid, while I-SNPs are designed for people who reside in nursing facilities or other institutions, and C-SNPs are designed for people with specific chronic conditions. I want to note before we leave this slide that the Medicare Medicaid plans will be phased out at the end of 2025 and transition to integrated care programs based on D-SNPs. For more details about D-SNPs, please visit the ICRC website, which has many resources for states. Slide 20, please. On this slide, we have included a pie chart that shows the choices that duly eligible individuals are making among the Medicare coverage options that I just described. In 2023, 40% of duly eligible individuals in the United States were in DSNPs, 37.5% remained in traditional fee-for-service Medicare, 18% were in regular non-SNP Medicare Advantage plans, and small percentages were in MMPs, C-SNPs, I-SNPs, or PACE plans. Slide 21, please. It's also worth noting that Medicare Advantage has become an increasingly popular choice among duly eligible individuals in recent years. The proportion of duly eligible individuals in Medicare Advantage plans has grown from just 18% in 2009 to 60% in 2023. The graph on this slide includes both full and partial benefit duly eligible individuals, and enrollment in Medicare Advantage plans include enrollment in special needs plans, as well as non-SNP Medicare Advantage plans. Slide 22, please. I also wanted to take a moment to note some important updates to Medicare that are taking effect in 2025 as a result of new rules issued in 2024. So first, Medicare Advantage plan compensation will be capped and standardized for all agents and brokers, and they'll be prohibited from receiving volume-based bonuses for enrolling Medicare beneficiaries into certain plans. Next, the Centers for Medicare and Medicaid Services is imposing new limits on the distribution of personal beneficiary data by third-party marketing organizations to prevent these organizations from circumventing rules that protect Medicare beneficiaries from cold calls and other aggressive marketing tactics. Third, Medicare has updated Medicare Advantage plans network adequacy standards in order to improve access to behavioral health providers. This effort builds upon the addition of marriage and family therapists and mental health counselors as Medicare-covered providers by the Consolidated Appropriations Act of 2023. Finally, there are new special enrollment periods in 2025 for Part D and Medicare Advantage plans that are designed to promote aligned Medicare and Medicaid enrollment for duly eligible individuals. For details about those updates, see the CMS tool at the link provided in the enrollment box on this slide. Slide 23, please. To summarize this section, duly eligible individuals qualify for both Medicare and Medicaid and may be eligible for full or partial Medicaid benefits depending on their income and assets. Duly eligible individuals have choices for how they receive their Medicare benefits, including traditional Medicare, Medicare Advantage, PACE, and Medicare Medicaid plans. The majority of duly eligible individuals currently receive Medicare benefits through a Medicare Advantage plan. Finally, 2025 changes to Medicare include updates to compensation for agents and brokers, data protections, behavioral health network standards, and special enrollment periods for duly eligible individuals. Now, I'll pass it off to Nita to present the final section of our presentation on the roles of Medicare and Medicaid in serving duly eligible individuals.
Thank you, Ken. In this next section, I will go over the different roles that Medicare and Medicaid play in serving dually eligible individuals. Slide 25, please. First, although we often say that Medicare is a primary payer for dually eligible individuals, the reality is a bit more complicated. So, for example, Medicare is a primary payer for inpatient and outpatient care and skilled nursing facilities services. However, Medicaid is a primary payer for custodial care in nursing facilities, home and community-based services, and non-emergency medical transportation. When a dually eligible individual receives mental health services, substance use disorder, home health care, or durable medical equipment, Medicare or Medicaid might be the primary payer, depending on the service that the person is receiving, whether they qualify for coverage of that service under either program and the specific services covered under a state's Medicaid state plan. It's also important to note that Medicaid benefits vary by state, so it's not possible to identify all of the situations where Medicaid would serve as a primary payer for these services on a national level. I'll go into more detail on each of these services in the next few slides and highlight some of the key aspects of the relationships between Medicare and Medicaid coverage for each. Slide 26, please. As I mentioned on the previous slide, Medicare is a primary payer for inpatient and outpatient services, such as hospital care and clinic or office visits. Medicare also covers ambulance transportation to a hospital or a skilled nursing facility for medically necessary care. Medicaid covers these services on a secondary basis for dually eligible individuals, either by covering Medicare cost sharing or by providing coverage that wraps around Medicare for full benefit dually eligible individuals. Medicaid may also cover additional services beyond what Medicare covers, depending on the Medicaid state plan. Slide 27, please. Medicare covers inpatient mental health services, like inpatient psychiatric care in a general or a freestanding psychiatric hospital, but that coverage has an 190-day lifetime limit. Medicare also covers outpatient mental health services provided by approved healthcare professionals, which may include services like individual and group psychotherapy, psychiatric diagnostic interviews, medication management, and other services and therapies. And Medicare covers prescription drugs to treat mental health conditions. Under Medicaid, states must cover a wide range of mental health services, such as inpatient and hospital services, psychiatric services, and rehabilitative services, among others. Additionally, most states cover several optional services, including non-medical support services, some of which might not be covered by Medicare. It's worth noting that many states may not cover services and institutions for mental diseases for people who are between the ages of 21 and 65 due to an exclusion in coverage for these services in Medicaid statute. Some states do provide this coverage now, though, through avenues like the Section 1115 waivers or in lieu of services. In states that do not provide this coverage, dually eligible individuals under the age of 65 can still receive Medicare coverage for inpatient psychiatric care. Slide 28, please. Medicare covers many substance use disorder treatment services as well, such as services provided in general or psychiatric hospitals with the same limits on use as with mental health services. Medicare also covers outpatient substance use disorder services, certified opioid treatment programs, and medication-assisted therapy, alcohol and other drug misuse screenings, and counseling and alcohol treatment, detoxification, inpatient stays, outpatient hospital treatment, rehabilitation services, and tobacco cessation counseling. Medicaid covers medication-assisted treatment for both alcohol use disorder and opioid use disorder, and many states provide a variety of other substance use disorders, such as detoxification, psychotherapy, peer support, and crisis intervention through Medicaid state plan services and/or Section 1115 demonstrations. In some cases, states may provide services that go beyond what Medicare could cover. Therefore, Medicaid becomes the primary payer for those services. Slide 29, please. For nursing facility services and home and community-based services, Medicaid's coverage is much more comprehensive than Medicare's. Medicare will cover in a skilled nursing facility only after a 3-day minimum medically necessary inpatient hospital stay. To qualify for skilled nursing facility care, an individual must need daily skilled care like intravenous fluids or medications or physical therapy. Medicare does not cover non-medical long-term nursing facility care or home and community-based services that are needed over the long term. In contrast, Medicaid will cover short-term skilled care without requiring a 3-day hospital stay. And Medicaid also covers long-term custodial nursing facility care to provide assistance with activities of daily living, as well as home and community-based services. Slide 30, please. For home health services to be covered by Medicare, the beneficiary must require skilled care like physical or occupational therapy. Medicare will also only covers home health services if the individual's needs for those services is part-time and intermittent and the beneficiary is homebound. In both skilled nursing facility and home health care, Medicare's continued coverage of therapy services as part of a maintenance program is not determined solely on the presence or absence of a beneficiary's potential for improvement from the therapy, but rather on the beneficiary's ongoing need for skilled care. Finally, Medicare-covered home health services must be provided by a Medicare-certified home health agency. Medicaid covers a much broader range of non-medical home care provided through long-term services and supports, like home delivered meals and personal care services. With Medicaid, home health services are also covered under a wider range of circumstances. For example, Medicaid does not require that beneficiaries be homebound. Because many dually eligible individuals need long-term services and supports, in particular, it is important to understand that those services will primarily be covered by Medicaid. Slide 31, please. Medicare coverage of durable medical equipment is limited to those items that can be used repeatedly, that are needed for a medical reason, and that are used in the home. With Medicare, durable medical equipment must be ordered by a Medicare-enrolled doctor or other healthcare provider. In contrast, Medicaid coverage of durable medical equipment includes equipment that beneficiaries can use in a variety of settings where normal life activities take place. It also covers items that are disposable and items that are used for safety or that are intended to make an individual more comfortable. Again, Medicaid pays for these services for dually eligible individuals, where Medicare coverage is limited. Slide 32, please. The final benefit that we'll look at today is non-emergency medical transportation services, for which Medicaid is generally the primary payer for dually eligible individuals. Medicare covers non-emergency ambulance transportation only if a physician states in writing that it is medically necessary and use of other forms of transportation would endanger the beneficiary's health. In contrast, Medicaid typically covers transportation expenses to any medical provider by ambulance, taxi, or other appropriate modes for exams or treatment. Slide 33, please. To highlight some of the key takeaways from this section, Medicare is a primary payer for most primary and acute care services a dually eligible individual may need, but Medicaid is a primary payer for most long-term services and supports and non-emergency medical transportation benefits. The primary payer for several service types, like behavioral health, home health, and durable medical equipment, depends on the specific services rendered, the circumstances involved, and the coverage offered under the state's Medicaid state plan. Slide 34, please. Okay, that's all I have for now. I'm going to pass it over to Haley, who's going to moderate the Q&A. Slide 35, please.
Thank you, Nita and Ken, for your great presentations. So we're going to open it up now for questions. And to ask your questions, you can submit those through the Q&A icon that's located at the bottom of the screen. And we have one question in there that's been answered already. So as a reminder, we did send slides to all registrants on April 16th, and we'll also send around slides after the call along with a recording of the webinar. Let me see. So I see another question. This one is for Ken. So this person says, I see there are a lot of potential Medicare coverage options for dually eligible individuals. So how do people choose where to enroll?
Yeah, thanks, Haley. So yes, there are many potential Medicare coverage options for dually eligible individuals. To some extent, options may be limited by where the individual lives. So for example, dual eligible special needs plans and program of all-inclusive care for the elderly are not available in all areas. Other factors that affect which Medicare coverage option an individual selects include things like provider availability, supplemental benefit offerings, and of course, out-of-pocket costs. So for example, certain dually eligible individuals may prefer to enroll in original Medicare because they can see any provider that accepts Medicare. Another individual may be interested in a specific DSNP that coordinates their Medicare and Medicaid benefits, or another Medicare Advantage plan that has their primary care provider in its network.
Thank you, Ken. That's super helpful. This next question is for Nita. How is the coverage overlap between Medicare and Medicaid different for full benefit and for partial benefit dually eligible individuals?
Yeah, thanks, Haley. When an individual has full benefits from Medicare and Medicaid services, Medicare is generally the primary payer for medical services, where Medicaid covers services that Medicare does not cover, like long-term services and supports and some behavioral health services, as well as like Medicare cost sharing to the extent where the individual, to the extent that the individual qualifies for that. For partial benefit dually eligible individuals, on the other hand, they do not receive full Medicaid benefits. So when these individuals receive services, they use their Medicare coverage first, and then Medicaid might cover their Medicare cost sharing.
Thanks so much. And this other question, I'll throw this one to Ken. If a person does not have 40 work credits to qualify for premium-free Part A, and that person has low income, can they get financial support for the monthly premium?
Yeah, so the answer is yes. If someone does not have 40 work credits and has a low income, they may be able to get financial assistance through Medicare savings programs. At a high level, Medicare savings programs are Medicaid programs that provide dually eligible individuals financial assistance with premiums or deductibles and other cost sharing if they meet certain income and asset requirements. So there are currently 4 types of Medicare savings programs, each with different eligibility criteria, and they cover different Medicare cost sharing requirements. But individuals who qualify for the Qualified Medicare Beneficiary or QIMBY program have their Medicare Part A and B premiums, deductibles, coinsurance, and copayments covered, including the Part A premium owed by people who don't have the 40 work credits.
Great, thank you, Ken. This next question, I think I'll throw to Nancy from CHCS. So the question is, what is the look back period to determine financial eligibility for Medicare and Medicaid?
Sure, Haley, I'm happy to take that one. So in Medicare, there is no look back period because it's not, eligibility is not determined on income. Oh, excuse me. For Medicaid, in almost all states, all except California, the look back period is 5 years or 60 months. Currently, California is phasing out its look back period, and that will be phased out by 2026. I believe it's 30 months right now, but it's being in the process of being phased out.
Great, thank you so much, Nancy. This next question, I'll toss this one to Nita. So can you give an example of durable medical equipment that Medicare would not cover?
Yeah, sure. Thanks, Haley. One example would be a seat for use in the bathtub or a shower. Medicare would deny this item just because it's used for the purposes of comfort or convenience. And it's a hygienic equipment and not primarily medical in nature.
Super helpful. Thanks, Nita. This other question is for Ken. So you mentioned that in Medicare Part A, there's a deductible for each inpatient benefit period. And so this person's wondering if you could say a little more or define what is a benefit period.
Yeah, thanks, Haley. A benefit period is the way that original Medicare measures a person's use of hospital and skilled nursing facility services. So a benefit period begins the day a person is admitted as an inpatient in a hospital or skilled nursing facility. The benefit period ends when the individual hasn't received any inpatient hospital care or skilled care in a skilled nursing facility for 60 days in a row. So if they're readmitted within 60 days, that new admission is part of the benefit period. If they go into a hospital or skilled nursing facility after one benefit period has ended, then a new benefit period begins. The person must pay the inpatient hospital deductible for each benefit period, and there's no limit to the number of benefit periods an individual can have.
Thank you, Ken. I see one more question for now. So if anyone has additional questions, feel free to put them in the Q&A. But for now, the last question I see is another one focused on clarifications around definitions. So Nita, this is about home health coverage. So what does it mean for a beneficiary to be homebound so that they could qualify for Medicare home health coverage?
Thanks, Haley. The homebound requirement for Medicare home health coverage, it just means that a doctor has determined that either because of an illness or an injury that the beneficiary can't leave their home without using an assistive device. So that would be anything like a cane, wheelchair, a walker, crutches, or special transportation, or even if they need help from another person. Or because of their condition, leaving their home is not medically recommended. Also, the physician has to certify that the person is not typically able to leave home, and that leaving home would require a considerable amount of effort or just plainly not be possible without major effort. So
that's super helpful. Thank you, Nita. So those were all of the questions that I saw. So I guess we will end the Q&A there, and I'll turn it back to Malia to close us out.
Thanks, Haley. And thank you everyone for participating in today's webinar. And thank you to all of our presenters. If you would like to revisit today's conversation and the slides, a recording of the call and the presentation will be uploaded to the ICRC website and shared with all attendees in the coming days.
I urge you all to visit the website where you can find links to past webinars and briefs and also submit TA requests. We hope that this has been valuable for you all today. And if you're logged into Zoom, please complete the survey that will appear at the end of the webinar. We're looking forward to reviewing your feedback and making any changes to future webinars. The survey will also be sent through email with the recording and slides after the webinar if you are unable to complete the survey today. So thank you everyone for your time today, and I hope you enjoy the rest of your day.